Hello everyone, my name is Marrit and I'm going to talk to you about my project which was recently published, which compares mannequins and simulated patients in a multidisciplinary medical simulation program. A little bit about me first of all. I'm a doctor working in Bristol in the United Kingdom. I'm currently doing my specialty training in internal medicine, but beside my clinical role I've got a special interest in education and especially in simulation education. I think the best way to use simulation is through training human factors and non-technical skills. And those kind of skills are best trained in a multidisciplinary team because all of our work is in a multi-professional environment. So that's, I think, how we should be training as well. And that's also how we've approached simulation in this project. So let's get started. First of all, a little bit of background about simulation. A lot of you might have had some experience with simulation in the past, but simulation means learning in a true-to-life environment which mirrors the real working environment, but which creates a safe space in which we can learn. So often simulation training is provided using a high-fidelity manikin, which is essentially a robot. I've got a picture of one on the slide. But it's a robot that can be controlled by an operator to have all of its sort of physiological functions changed and altered, and which then allows you to go through a scenario for the purpose of training a group of learners. So often, historically, simulation training has become synonymous with mannequin-based training, but we found in our local practice that we were increasingly using actors or simulated patients to play the role of a patient rather than using a mannequin. And the benefit in our eyes of this was that it creates a much more realistic environment for the learners to interact with the simulated patient and respond in a much more realistic way like they would in the real clinical environment. So our objectives in this study were to compare between mannequins and simulated patients, which approach makes healthcare professionals feel more comfortable, which leads to the greatest improvements in confidence, and which is the most beneficial to learning through simulation. So we did this through a survey-based simulation, a survey-based observational study, which we embedded in our existing multidisciplinary in situ simulation program. So this program is a regular program that runs in the University Hospitals of Bristol Trust, where we have a group of simulation facilitators from multiple backgrounds. So we've got nurses, we've got doctors, we've got an operating department practitioner, and they, as a team, go in and take the equipment into the clinical area that a clinical team will be working in and run a simulation in their actual teams, in their actual areas, using their actual equipment. So between September and December 2019, so just before the pandemic, we would run the same scenarios in this program, but we would run it either with a mannequin or with a simulated patient, and we would then ask afterwards our participants to complete a survey in which they would give us their opinions on what their preferences were between mannequins and simulated patients, what they found most comfortable and what they found was most beneficial to their learning. We did have to exclude some scenarios, so that was mainly scenarios that were very clearly suited to a specific type of simulation. So some mental health based communication scenarios are clearly much more suited to an actor which you can interact with in a very natural way rather than to a mannequin, whereas other scenarios such as those requiring doing CPR and chest compressions or those requiring intubating someone clearly can't safely be done on an actor, so require a mannequin. So those kind of scenarios were excluded, but we had quite a wide range of scenarios that we were able to include. And as you can see, those were mostly relatively acute clinical scenarios, and we used a very structured script which had stages that we would work through and we would move to the next stage depending on the participants' actions. So we used the exact same scripts in both arms to try and standardize it as much as possible. So this next slide shows the survey that we used. This was an option. They had an option of completing this on paper, and this is a screenshot of the paper version that you're looking at on the screen now. Or they could do it as a Google form where we had a QR code which they could scan using their phone and then fill in the survey with the same questions on their phones. We had a mix of questions of some that were used for our study, so that we put in specifically for this project, and some that were already there and required as part of the organisation's regular feedback process for the simulation. And we did this all in one form so that we didn't have to ask the busy clinical staff who were already taking time out of their days to attend extra training. So they didn't have to then also fill in 2 feedback forms. And I think because we kept it relatively streamlined and used one form, we had a 100% response rate. So everyone who was involved in our simulations for this study also completed the feedback form. You might also notice that we used the term actor rather than simulated patient to describe the simulated patient in this form, and that was because this is a much more colloquial, well-known term that didn't require further explanation to the participants, so it made it easier for them to understand. Okay, so we'll go through some of our results now. Oh, first of all, I'll talk to you about our participants. So we ran 40 scenarios and we had 204 responses in total. We encouraged the staff in the clinical area that we would go to all join in the simulation. And as you can see, our largest professional group was nurses, registered nurses, but we had for every simulation a mix of professions. So we never had a session that had only nurses involved. All of these were run in the University Hospitals of Bristol Trust. So 47 were in a peripheral community hospital that's mainly focused on rehabilitation, and 157 respondents worked in the large city centre hospital complex, which makes up inpatient wards, the outpatient unit. We had people from the eye hospital, we had the operating theatres, we went to the dentistry unit. So we had quite a wide cross-section of our clinical teams involved in this. We also carried out a post-hoc power analysis to check on our sample size using the G-STAR power tool, and that showed that it was adequately powered for our study. So, time to look at some results now. So first of all, we've got this slide here which shows what our learners' self-reported preferences were. So as you can see, most of our learners, so 119 of them, preferred working with a simulated patient. 35 of them, which was 17%, preferred working with a manikin, and about a quarter, so 50 respondents, had no preference between the two. Looking at learner confidence, so this was self-reported confidence before and after using a Likert type scale where we asked them to rate their confidence from 1 at the lowest to 5 at the highest. And as you can see, both groups achieved a statistically significant increase in confidence. So both the simulated patient group and the manikin group felt that they were more confident after than before. For the simulated patients, we had an increase of 1.05 points, and for the manikins, we had an increase of 0.83 points. The difference in confidence change, however, between these two groups was not significant. So our cutoff for statistical significance in this study was p equals less than 0.05, and as you can see, our p-value was 0.0536, so above the threshold. So next we looked at the self-reported benefit to learning. So what we did was we asked our participants to rate how much they agreed with the phrase that the actor was most beneficial to their learning, or that a manikin was most beneficial to their learning. And they rated this from strongly disagree up to strongly agree. And then we assigned rankings of 1 to 5 depending on their rating. So as you can see, simulated patients were felt to provide significantly more benefit to learning. So the simulated patients, we had a score of 4.17, and for the manikins, a score of 2.97. And the difference between these was statistically significant. We also asked our participants to tell us why they felt that whatever they thought was brought the biggest benefit was more beneficial for them. Our most common answers for the simulated patient group were that it was more realistic, that it was better for communication, and that they liked that there were verbal and non-verbal cues that they could respond to. For the Manikin group, they felt that it was less pressure, they felt that they were not worried about hurting the mannequin, whereas they might have some concerns about hurting an actor, and that's why some preferred the Manikin group, so preferred working with a mannequin. So our key results really are that our learners believed that working with a simulated patient made them more comfortable, and that simulated patient-based simulation was more beneficial to learning than mannequin-based simulation. So now a little bit of a discussion about our results. So simulation training in general is uniquely suited to training human factors and non-technical skills. And what we found is that simulated patients created a more psychologically safe environment for learning because it made people feel more comfortable. And that's why we think that this is especially a very useful tool for training these team-working, non-technical skills. Additionally, it's quite useful to talk about some important considerations to think about when you're trying to run a simulated patient-based session. So the first important point is that we need to make sure that we do very good and very clear briefing of both the learners and the simulated patients. So for our actors or simulated patients, they need to know exactly what the script is, what the stages of the script are, and what structure we're trying to achieve to reach the learning objectives for our participants. So this is important because, for obvious reasons, it is much more difficult to steer and control a simulated patient during a scenario than it is to control a mannequin, which, you know, is essentially a robot. Also, it's important to brief your learners. So your learners need to know, first of all, what information they're getting from what source. So there will be the option of getting information from speaking to your simulated patient. There will be some information that they might need to get from talking to the facilitator. And what we often use is a screen on which the patient's observations and vital signs are. So if you're wanting to simulate a tachycardic patient, it's much easier to put a heart rate that is fast on a screen rather than your participants feeling the pulse of your simulated patient and finding, hopefully, that they're not especially tachycardic, and that can cause some confusion. So you need to make it quite clear where they're finding certain bits of information to progress through the scenario. Additionally, you need to make clear what procedures and actions they are meant to be performing on the simulated patient. So you might want them to examine your simulated patient, but you might not want them to cannulate or perform phlebotomy on your simulated patient for obvious reasons. And it's for the flow of the scenario and for the safety of your actor. You want to make it really clear to your learners what they're meant to be doing and not doing. Additionally, it's good to agree a way in advance to communicate during the scenario with your simulated patient. So that can be through eye contact, gestures, and through giving them a way of stepping out of the scenario if they feel uncomfortable or unsafe, because it can be quite an intense experience being that simulated patient. And you want to make them feel safe and comfortable and have a way of escaping, as well as give you a way of steering the scenario if you need to. So I think the most important point, though, on this slide is that your choice of simulation modality has to depend on your scenario. So some scenarios, as we said, will be particularly suited to using an actor, and some will be much more appropriate for using a mannequin. And although we've shown that our participants preferred, in situations in which both could be used, they preferred using a simulated patient, there will always be scenarios in which a mannequin is more appropriate, and the educator will have to look at their learning objectives and then find what the best way is of achieving those. So a little bit about the limitations of this study. First of all, we used self-reported Likert scales. And the useful thing about this is that, as we were talking about psychological safety, it's good to know what your learners are feeling and what they feel comfortable with. So from that perspective, they're very useful. But it does mean that we were using a subjective measure of learner confidence and their ability to deal with the situation, rather than using an objective measure of their learning and skills. So that's something to be aware of when you interpret these results. Additionally, we embedded the study in an existing teaching program. This was important for the ethics of the study, that we weren't changing the learning experience of our participants. It also is quite good because it meant that we made sure that it was widely applicable to a variety of settings, and it also allowed us to have a good sample size. However, it meant that our facilitators were primarily focused on educating rather than on keeping all of the conditions standardized for research purposes. So it had to be a teaching session first and then a research project second. We also provided the scenarios in a wide range of different environments. So, for example, if we had an anaphylaxis scenario, we would be having a slightly different flow to that if we were running it in an outpatient department to if we were running it in an operating theatre, because we had different teams with different experiences, and also we would have the teams use their own equipment, but that had to change the structure of the scenario a little bit. However, in an attempt to try and standardize this as much as possible, we did use the same scenario scripts for both arms. So as we said, it was a very structured script that was kept the same. And we had the same two facilitators, which was me and my co-author Josh. So we were the same two people who ran all of the scenarios to try and make it as standardized as possible. So in conclusion, we found that learners believed that simulated patient-based training makes them more comfortable and is more beneficial to their learning. However, although certain scenarios might be more suited to a specific approach, so to either an actor or a mannequin, but in scenarios that can be flexibly provided using either type of simulation, we think that educators should give a greater consideration to using simulated patients, rather than automatically jumping to using a mannequin. So, thank you very much for listening to my presentation. If you want to learn more, first of all, you can read the paper, which was published in the Journal for the Educational Evaluation of Healthcare Professionals, and it's an open access journal, so everyone should be able to read it without difficulties. Additionally, if you have any questions or comments, feel free to email me. I've put my email address in the left bottom of the slide. Well, thank you very much for your time and for listening, and enjoy the rest of your day.